Well, hello and good evening. My name is Dr. Ron Perry, and I am a clinical professor and a director at the Gable Center for Restorative Dental Research at Tufts University in Boston. But more importantly, I am a practicing clinician, and I practice 4 days a week, and I'm at the university 3 days a week, so you can figure out the math on one of those things. But tonight, what I want to talk about is impressive impressions and a key to a successful final restoration. You know, taking an impression can cause a high level of anxiety for most clinicians. There's everything from the communication with the lab to actually taking the impression itself. And tonight, what I hope to do, and the purpose of what I really want to do tonight, is discuss the most common techniques and problems and materials and devices and tissue management. And there's definitely a list of materials that I want to try to get through tonight, as much as we possibly can. But more importantly, I want to try to give you some tips, some costs of taking the impression, what the real cost is, not just the material itself, but what it actually costs you in chairside time. And I'll also talk about some disinfecting and some trays and some lab communications. And we'll also talk about some of the future with the scannable impressions that are now making more of a headway. So with that, let's begin. You can see in the picture here we have Tufts University. We're the second largest dental school in the country. We just did a major renovation of about $160 million and added 5 more floors. And on the bottom over here, you'd see this is just a picture of my office and my private practice. This is my waiting room. So as we talk about tonight, I want to talk about taking an impression, but we're just isolating one procedure. Obviously, we're trying to get to the final restoration. I want to talk about aesthetics and function, and we can make nice-looking restorations, but we've got to make sure that they function at the same time. We've got to talk about the proper impression techniques and some of the problems that are associated with that. I'm actually going to share with you, I know probably no one in this audience has any problems with taking an impression, but you may know some colleagues that do. And with that, I'm going to try to show some of the problems that are out there of actual cases that have been received by dental laboratories. And also, how do I select the correct impression material? Is there a difference? Should I go with name brands or should I go with aftermarket brands? I'm going to try to talk about that. And I'll also talk about some of the real costs of, like, as I said, of taking the impression and talking about some of the future alternatives that we have. Well, we take some of these impressions and make these restorations because people technically want to look beautiful, and especially in our society today. I take a lot of continuing education courses. I give a lot of continuing education courses, but I also read a lot of these magazines that my patients see. And why do I read them? Because the manufacturers have gotten smarter as far as going right to the consumer. So people are asking for lumineers, which are veneers that we've been doing for a number of years. So I just want to be educated in what's going on there. I want to see what some of the trends are going on. People do want to look beautiful, and they'll come in and bring in magazines, or I want that smile, or I like the Julia Roberts smile, I want the white teeth, and the whiter the better. Most people want it as white as they possibly can, and a lot of our patients are whitening and whitening toothpaste, and they're using different whitening systems, everything down to Zoom whitening, and you can name 10 other brands that are out there. So whitening, white teeth, straight teeth, everybody wants to look better. They want to take care of the spaces that they have in teeth. They want to take care of the stains. They want to close the diastomers. They want the perfect smile. They want the Hollywood smile. And we can do this today because we have numerous restorations that are out there, anything from different feldspatic porcelains to zirconia restorations to Emax. I mean, there's a ton of restorations that we can change and alter the appearance and give them the translucency, the color, the whiteness, the contours, the closing of the gaps, and give them the pretty smile. So we have a lot of things at our disposal today, but to get there, we still have to take an impression. And we have to take into consideration the age of the patient. We have to look at the structure of what's underneath the teeth, whether there's decay or there's structural integrity. We have to look at the color of the tooth, not only from the outside of the tooth, but from the inside too. We have to look at the occlusion and see if there's any parafunctional habits, and see if anything is broken down, and why did that tooth break down, and if I put something there again, will it break again? So we have to look at aesthetics and we have to look at function and make sure that they're both in line with each other. We have to look at how much reduction of a tooth do we have to do. Do we have enough space for it? What's the classification? If they're class 2 or class 1 or edge to edge, that may play into effect of what material we're going to choose. Also, where the margin location might be. Do we have to do some periodontal work to change the marginal integrity or make the teeth look longer? And what's going to be the clinical performance of these teeth? Do we have any parafunctional habits that are they're chewing pencils or chopping on ice, or they're bruxers? So these are all things that we have to consider. And then once we do that, then we have to pick what material there is. And again, there's numerous materials that are out there that we can choose from, and I truly can go today from a PFM, which many labs can do a great job with a PFM, but some of these other materials, they may or may not, depending on if they're not using it as much. But we definitely have to take a look into this, and we have to keep in mind the what type of preparation that we're going to prepare for these teeth. Normally, what we would do is we prepared with PFMs, we do feather edges, we do bevels, maybe modified shoulders, but with the new all glass type of restorations, we have to kind of go with a chamfer or more rounded line angles. We can't go with shoulders or anything that's going to be sharp. So most of our preparations are going to be modifications of a chamfer or a deep chamfer with rounded edges, with no sharp line angles, so nothing's going to break. And we have to keep in mind function and aesthetics. It's nice to look pretty, but they has to have the health, has the function, has to have the comfort, has to have form to become aesthetic. So as we diagnose this in our treatment planning before we take our impression, we really want to know what our final outcome is going to be and where we're going to be before we even cut a tooth. We want to look at all the pathology. We want to see what the treatment is. We want to see if there's any occlusal alterations or any changes or effects that we have to change for that patient to get the outcome that's there. And some facts that are out there is that there's a lot of people that are bruxers, and especially I'm noticing it a lot more now, especially in my area of the country where the economy is wavering up and down. But a lot of people do grind their teeth. They're bruxers, and they don't even realize it. These are some facts that are out there that basically when your teeth are in contact, they're approximately 20 to 25 minutes for 3 meals a day. They put a tremendous amount of force on the back of the teeth. People don't even realize it. I've made many mouth guards and many TMJ splints and so forth. And once people have worn them, they've realized that they feel a lot better. So some of these are some of the facts. But not only do we have to keep in mind of all these other things as we're diagnosing and doing function and aesthetics, we have to look at what people have in their mouths. People still have PFMs, or they have amalgams, or they have composites. And now we have to not only look at our final outcome, we have to match to existing restorations. We have to either match to existing PFMs or some feldspatic porcelains. Maybe we do an Empress 1, Empress 2, Emaxes, and so forth to try to match the color, because there's a hodgepodge of different materials that are out there, and we have to be able to take that. So we can take a case similar to this, that the patient has composite materials, has an older PFMs, has some staining, some malocclusion, is actually wearing a partial denture, has receding gums that are here. This is some aesthetic considerations. Has receding gums up in here, maybe some recurrent decay. And we have to look at that and then try to treatment plan that and prepare the teeth. And not only prepare the teeth, we have to prepare the shade for the laboratory, communicate with the lab, and figure out what the dentin shade is, what the enamel shade is, and give them as much information. And look at alter the occlusal malalignment of the teeth here to make it more aesthetically pleasing, and again, keeping in mind the function and aesthetics. And then working that out in our provisional material in our restoration, and basically the test drive for the patient, and listening to sibilant sounds and everything else that goes along with function, and then with aesthetics, to come down to taking our final impression of keeping the tissue managed and well under control and not bleeding, so that when we cement in our final restorations, whether they're all porcelain, zirconia, or Emax, or whatever the case, whatever we choose, depending on what the situation calls for here, and then cementing them in so that we can go from this before to after and getting a more pleasing smile, and then keeping in conformity of what the patient has in their mouth with older PFMs, keeping those there, and with the partials, and able to give them an aesthetic consideration with function and aesthetics all in line with each other. So it functions, it works well, it's pleasing, and the patient is usually can be happy, especially with the materials of choice today. So the question is, have things really gotten better, or you know, is it status quo? Well, I would have to say that, you know, we've had bridges around for a long time, but bridges in 200 BC versus today and tomorrow, where we have truly metal-free restorations. PFM, I have nothing against the PFM. My PFM's a great restoration. I still use them. But again, with the cost and fluctuation of metals, it's becoming more cost prohibitive to use these materials, and to go with the zirconia type restorations are becoming more cost effective. So some people may argue that gold is maybe a better choice, and it's more malleable, and it definitely does work very well. But most of my patients, they want a white tooth. They want something that looks white, it functions right, and feels good to them. And there's nothing wrong with this restoration, but again, people want white teeth. They want white fillings. And to do that, we have to take an impression. We have to prepare teeth. We have to take an impression, use an impression material, and material that is basically making an impression of the teeth and some of the surrounding oral tissues that they have in the mouth. And so that we can then make a model from this and bring it to the laboratory. So what do we have for materials that we look at? We look at different types of elastomeric impression materials, and we have polysulfides, we have polyethers, we have silicones, and we have polyvinyl siloxanes. What I really want to concentrate on tonight will be predominantly polyethers and polyvinyl siloxanes, because those are the predominantly the materials that are being used today. And I'm going to try to break this down for you so you'll see what I'm talking about. Well, as we look at polyether impression materials, the basic makeup of the polyethers, which have been around since the 1950s when SB had it, now it's owned by 3M/SB. I actually had the opportunity to go into Seefeld, Germany, and actually seeing them make this impression material. And it's quite cumbersome because they have to go into big vats, and they actually have people that climb into these big vats to make this impression material because that's the only way they can clean it. But it's basically made up of a polyether. It has a cross-linking agent of a sulfate, is glycol-based plasticizers, and a filler of silica. And with this, we have the polyether material, and then we have polyvinyl siloxane materials, polyvinyl materials, which are silicone polymers, and they use chlorolplatinic acid, and they have a silica filler. And what's great about these materials is that they're very dimensionally stable. They don't have to be poured up right away. It's not like an alginate impression that you have to pour it up right away. So, which is great, especially if it has to be placed in the mail and brought to the laboratory. So you have some time to pour this up. It's a stiff enough material, so it doesn't alter its shape or deform. It's as it's going through its stages. Not only when you're taking the impression, so you get an exact negative of what you have there, and then becomes a positive when the laboratory pours it up in stone. And usually these materials today are mixed on an auto mix system, or they use a gun and with various tips. And as a clinician, and I'm sure there's plenty of clinicians out there that probably will feel the same way, is that it gets very confusing, especially with the number of guns, the number of tips, which tip goes with which ratio, because some of the cartridges look very similar, and some of the ratios are either 10-to-1, 4-to-1, 2-to-1, 1-to-1, and it can be very, very confusing if you're not careful with that, and it can affect the final outcome of the impression. But the bottom line is you want to get an accurate impression. Now, here's a single unit, and most clinicians will use a triple tray of some sort, a quadrant tray, for a single unit like this. But if you talk to most laboratories, they would ask for a full arch impression. But most dentists will look at this and say, well, I don't want to have to take all this impression material or use all this impression material for one tooth. It seems like a lot of money here. But the laboratory is going to argue with you that they can actually give you a better restoration, a final restoration, if you give them a full arch impression, because they have the contralateral side to look at. They look at balancing side, the occlusion. They can give you better anatomy, less adjustments, and so forth and so on. Most clinicians will not use a custom tray. They'll use a stock tray. They'll spend most of their time trying to whittle it down or reshape it or recarve it in any way they possibly can not to make a custom tray. But if you don't, you have to have some guidelines, and we're going to talk about some of those guidelines. But for the full arch impression, you have to have a tray that actually fits the patient. If you don't have a tray that fits properly, you're going to have some distortions, and you're going to have a bad final product. Well, if you know, in the end, we all know as clinicians, if the final restoration doesn't fit, we know what the problem is. It's that lab. It's that damn lab. They screwed it up again. Or is it the lab, or is it us? I have to tell you today, the materials are extremely good. They're very, very accurate. But there are some things that we may be doing, and we're not even aware of it, that can cause a bad impression. And it may not even be the dentist. It could be the assistant. And I'm going to go through some of those problem areas where it can cause a bad problem. But there was a survey that was done at our university a few years back in 2005, where we surveyed different impression laboratories throughout the country, because we wanted to find out where the problem was. Is there a problem with impression materials, or basically what we wanted to find out at the time was what impression materials were people using. Impression materials, just so you know, is about a $300 million market in the United States. So you have the major players that are trying to sell you impression material, and is there a difference? Basically, you've got polyvinyl siloxanes, which are basically 59% of the market, and you've got polyethers, which is about 25% of the market. And before polyvinyls, the newer ones that are out today, before those, polyethers used to be a higher market, between 30 and 35%. So that's quite a big percentage of a $300 million market. We also have reversible hydrocolloids that we found out that are still in play, which are a great impression material, very, very cheap, but very cumbersome, because you had to have all this apparatus and, the water bath on, and if you didn't put it on at the right time, or your assistant didn't turn it on, it could be an issue. What was really, really interesting, what we found out from the survey, was this little statistic here, that 9% of other materials that are out there, which included alginates, rubber bases, and some unidentifiable materials that we discovered. And what were those unidentifiable materials? Well, we found out that Home Depot and Lowe's and other hardware manufacturing companies, people were actually using these materials. I'm not even making this up, because we would have caulking and materials being placed in people's mouths, and laboratories were getting this and actually fabricating final restorations from this. So it just boggled my mind when I found this out, and made it very, very interesting. But from the survey, we found out a lot of different things, and I'll share those with you as we move along. And from these impression materials, we have many choices. And it comes down to really personal preference, because some of the materials that people like are either very, very stiff, or they're runny, or they're blue, or they're pink, or they match their operatories. And people want certain materials, or they're used to using certain materials, and they know how they work. A lot of the materials of people turn about and they go, well, they all look good, so how do I choose? Which one do I put my finger into the fishbowl, and how do I pick it out? Because no matter what material I use, I still have to take a basic impression. I have to get an impression. I have to look at the preference of material that the dentist chooses for the procedure. I have to prepare the teeth and hopefully do the right preparation, depending on what type of final restoration that I want. Once I've prepared the teeth and or the tooth, or whatever the case may call for, I have to have the tissue managed so it's not bleeding, and then maybe use a light body type impression material, syringe that around the impression, along with a heavier body material, place in a tray, whether that's a quadrant tray or a full arch tray, and then place that in the patient's mouth, get the impression, and remove it, and then send it off. Well, actually disinfect it, label it, disinfect it, and we'll talk about that too, because that can be an issue, and sending it off to the laboratory. So that's our basic impression technique. It may be modified now. Some of these steps might be modified using the scanners. Not digital scanners. Some of the latter steps, not having to take the impression materials or having that taste in people's mouths, because people still do not like that material. So we have materials that are out there, and there's a ton of materials, everything from 3M's Imprint 3, the vinyl polysiloxanes. They come in a Pentamix machine, which has been great, or a gun system, along with various tips that go along with that, and make sure that you use the right tip with that, and these are all color-coded. Or our polyether, which is a very popular material, and this was a material that I used in dental school, and it's still being used in dental schools today. It's a very, it's a very effective material. It's very accurate, and it works, but it does have some drawbacks. If you've used the material, you know some of the drawbacks, especially if you're doing a full arch impression. It's hard sometimes to remove it. And I've had this experience on my own mother-in-law, and she's French, and I learned some different languages from what she's told me over the time. The next one, and that has the Pentamix machine too, and mostly all these materials will come with the, there's different Pentamix machines that are out there. DMG makes some. I know that Dentsply makes a Pentamix type machine. So there are different machines out there, so you don't have to just buy one. There's more out there. But the most important thing that we have to keep in mind is the tips, because each one of the tips can be different. These mixing cannulas actually mix the material, the base and catalyst that comes down in here, and each one of these tips may fit on, but if you're using the wrong tip, you can have the wrong mixing ratio and either set the material too quickly or not quick enough. Even the tip that goes onto the Pentamix machine can be an issue. So even though it looks very similar, it may not fit correctly, and it can affect the final impression. So keep an eye on that. If you're having a problem with impressions, this may be one of the links that may be the issue. So take a quick look at that. And also we have mixing tips. And we have different tips, as you can see, different angulations on different sides of the lumens, because we want to try to get down into the sulcus, because most of the preparations that we do are subgingival, and we have to take a look at those. So as we move along, it's still confusing. I took this picture years ago, just kind of showing the confusion, because, this tip goes with this one, this gun goes with that, and it got very confusing. So we spent some time trying to educate my assistants so that they make sure that they use the right material and the right tips for the right procedure. And with the auto mix system versus the old hand mix, it's made a huge difference on the outcome of the material, because when you were hand mixing it, you would incorporate a lot of the air bubbles, and with the auto mix systems we eliminate a lot of the air bubbles, and the air bubble was never here, it was always on the margin up in here. That was where the problem was. But these auto mix systems are very consistent. It's a consistent amount of mix, base and catalyst, setting time, which definitely cuts it down. If you've been practicing, I've been practicing 24 years. If you've been practicing for a while, you may have used some of the old polyvinyl siloxane materials, which weren't that great. And what would happen is it came down to contact angles. And the contact angle, if you had a very high contact angle, it didn't have a good wettability on the surface. It didn't flow very well. And the way we used to take care of that problem is that what we would do is we'd actually blow air and blow it around the material around to the surface, and that would then make it spread and go into the sulcus. However, what we would be doing at that same time is incorporating bubbles and voids and air voids into the final restoration. So it was very technique sensitive in doing that. What we really want is a low contact angle. And you can see that today the polyvinyl siloxane materials, like the Impergum, has a very low contact angle and has better wettability. A lot of the older materials, we had to keep them very dry. But I can tell you that if you keep the materials today extremely dry, you will get a bad impression. you will get a very poor impression. One material that comes in mind, especially, is with Aquasil. If you're using Dentsply's Aquasil, you will find that if you wet that, if you don't keep it slightly moist, you will have a problem with your final impression. So keeping a little bit of moisture definitely helps, and not drying it out. And with using some of these light body materials, they have a nice hydrophilicity to them, they have a nice wettability to them, and most of the name brand materials as they come along, they're going to wet the surface very nicely and give you a good impression as long as you do everything correctly. If you want to look at what these materials look like under electron microscope, this would be an Impergum type material, and it's really only one type of polyether. I can name another polyether that's out there, and it's not really a true polyether. It would be P2, which is Heraeus's product, but it's really a polyvinyl siloxane. It's really not a true polyether because it's just too expensive to duplicate it again. So 3M SB has a corner market on that, and this is what the a polyvinyl siloxane looks like under the cross-linking. It's very, very similar to a polyether material. So you can see the materials are, the gold standard has been the polyether, but again, these new polyvinyl siloxanes have taken the good qualities of the polyether and have made them even better, and taken the good qualities of the polyvinyl and kind of mixed it all together. So, as we look at some of the considerations of using a polyether material, it's a very stiff material. And if you want to remove it from the mouth, you've got to kind of rock it out. You've got to break that seal. If you have too much water or saliva or blood, it can affect the polyether. It does definitely has some hydrophilicity to it, especially if you disinfect it. It can absorb, and it can have dimensional stability, and that can be an issue depending on how you're disinfecting it. If you're letting it soak for a couple hours, that can definitely have a final outcome problem of having tight-fitting crowns or ill-fitting crowns. So just be careful with that, and we're going to go over disinfecting techniques just a little bit later in this presentation. So as we keep going along here, the bottom line is that we want to pick up the reproduction of the detail, and a lot of these polyvinyl siloxanes today will pick up this detail. You can even see the striations of the burr being picked up in the detail. So you can pick up a lot of this detail. They're very, very accurate as long as you use them well. So as we look at these materials, the older materials were kind of hydrophobic. They the moisture would kind of inhibit them and inhibit them from getting in intimate contact with the tooth surface that was prepared. And that's why we blew air on them and tried to get them in closer proximity up to the surface, where we had then hydrophilic materials that liked the water, but then the water would kind of get absorbed into the material, and you'd have some precision loss on that. So I like to call these materials today really hydroactive, where they like the water and they kind of push it out and they displace it to their advantage, and they get a more precise, more accurate adaptation to the tooth structure. The bottom line is we want an accurate impression. It doesn't matter what material you're using. If you stay with the name brands, I can tell you if you stay with a 3M, Dentsply, a Kerr, a Heraeus, these are manufacturers that actually test their materials. Anyway, whatever material we want to get an accurate impression. We want to get something that is blue, pink, purple, whatever the case may be. We want to keep moving with that. And we've got to then, to get that impression, we have to take care of the tissue management. We have to have the cheapest way is using cord. We can pack cord around that and deflect the tissue, keep the tissue from bleeding, and so we can take our final impression. And whether we're using a single cord or a double cord. If we're using a single cords work predominantly the best if the margin is actually at the gingival level or it's supragingival. If it's subgingival slightly or a little bit below, a two-corded system works extremely well. However, what most clinicians are using now is they'll use a cord, they'll use a single cord, and then use a modification of that. They'll use a laser, like a diode laser or a CO2 laser, and then just cut around the tissue to make sure that they get beyond the margins so they get a nice emergence profile for the laboratory to fabricate the final restoration. Or they'll use some type of hemostatic agent, and there's a lot of different ones that are out there. The bottom line is you want to be able to control the tissue, you want to be able to see the margins, you want to see the preparations, you want to be able to just be able to see it all the way around. If you can't see the margins and you can't see the cord, then place another cord. or place something to displace that tissue and leave it in long enough so that it will. You have to typically leave it in for at least between 5 and 8 minutes, up to 10 minutes. That'll help you give you a good final impression in tissue management. Now, there's about 125 different varieties of cords that are out there. There's plain, there's impregnated with or without hemostatic agents. There's twisted, there's braided, there's knitted. For the most part, most people find that the Ultradent cord is probably the best cord. This seems to be the most popular. I've talked with many clinicians over the years, and they keep going back to the Ultradent cord. I like this cord myself. And what you're going to find is you're going to use the 00 or the 0 cord predominantly, because what you're doing is, we're calling it packing the cord, but you're really trying to place the cord, because if you're really packing the cord and you're hitting that resistance, you're going to cause gingival recession, and that's not what you want to do. You really just want to put gentle pressure in there and make a V-shaped sulcus so that the tissue is displaced, and that knitted cord that Ultradent has actually springs out like a spring. So if you cut the cord, as a clinical tip, if you cut the cord too short and then try to stretch it, you've defeated the purpose of the cord, because it's almost like a spring in it. And so you want to make it a little bit longer than you need to have it. And the top of the cord should be visible. And if it's not, place another cord or use some of the other techniques that we just talked about, of either using a diode laser to gently take off the top layer, or using even electrosurgery is fine if you use a thin filament. So you want to pack the cord, leave enough of the extra cord so that you'll be able to grab it, and you pack the cord and push it down in here gently into the sulcus, and you put it on an angle, usually about a 45 to 60 degree angle to the tooth. And then you want to keep good tissue management, where all the fibers, periodontal fibers, are intact, versus bad tissue management. If you go into that resistance and you break through, you're going to end up with recession. So you want to make sure you pack enough around so that you can pull the cord out and keep it in there long enough and keep the tissue and the sulcular fluid from coming up to interfere with the final impression. So this is probably the most important aspect of getting a good impression final product. And most clinicians don't use a cord packing instrument. They'll use a periodontal probe or some other flat instrument. And the problem is that it slips off of the cord. Cord packing instruments are not that expensive. They're going to cost you probably around $20 or so. But they have a serrated end here that helps to pack the cord into the sulcus. So getting a nice thin cord packing instrument definitely will help the final product and help cut down your anxiety level of getting a good impression. Now, you can get away without a cord. There are other materials that are out there. A lot of us used to use, and I still like it, is the Expisil product by Kerr. And the problem with that material is that it worked extremely well, except if I had lower anteriors, it had such a wide metal lumen that I couldn't really get into proximal areas. That was really kind of a drawback. What 3M has come up with is this retraction capsule, which is basically using the same materials that is in Expisil, and then placing this material really into the sulcus. Is using the aluminum chloride like the Expisil, placing it in. You see this nice thin apparatus here, this nice tip here, goes right into the sulcus. You place that around there. You leave it in for approximately about 2 minutes. It gets the tissue nice and calm, opens up the sulcus, and then you just basically rinse it away, gently dry, and then take your final impression. I mean, it can't really be much simpler than that. Some people have even used this depending on the preparation that they have or the clinical situation, they actually would use this along with a cord. So they might put a single cord in there and then use this Expisil. Or you can use the tried and true and use with tissue management. You could use an electrosurgery. But again, I'm showing this in particular because if I was going to use electrosurgery, I have nothing against it, but you got to be kind of careful because it's like operation where you don't want to hit the tooth structure and you want to keep it parallel to that and just use a very thin filament because if not, the nose lights up and it can cause a lot of damage. So you got to be very careful with this and not take off too much. As we're moving along, we have what type of hemostatic agents do we have? Well, we have the aluminum chloride, which works extremely well. Ultradent's Vicostat, or however way you like to say it. It works extremely well, and you'll see it's got a ferric sulfate in it. It's got an ion in it, and what happens is you'll notice that the tissue will then turn black. And you got to make sure that you rinse it off. That's the only drawback on this, is if you're using this material, it works extremely well, keeps the fluid and the tissue under control, but you must rinse it off. When you think you have it rinsed off, you got to rinse it again, because it will definitely affect the final impression. So be very careful with that. It picks up that ferric sulfate. That's why you see that dark stain. Or there's some other materials that are out there, these Compre caps that are out there. They're kind of cool. You can put some pressure on that and then press it into the sulcus and open it up again. You're trying to see beyond the margins here. You want to see beyond that, so the emergence profile helps to give the laboratory better indication of what's going on. This is another material. I mean, we're going through these quickly, but there's a ton of other materials that are out there, and I'm just touching on the basis of it based on time limitations here. But this one's kind of interesting. This is a ceramic burr made by Axis Dental, and what you do is you put it in a high speed, no water, and you basically just go circumferentially around the tooth, around and around and around, and it cuts and burnishes and cauterizes all at the same time. It's probably going to cost you around, I think it's around $35 to $50 a burr. You'll probably get maybe 20 uses out of it, and then you have to throw it away. The only issue is that they have to keep it this thick, only because if it was too thin, it would break off. But just keep going around and around as fast as you can go, and it works extremely well. Just another option for some people that would like to try it. I think it works well, but it comes down to personal preferences. And then we come into disinfecting of our impression material. Now, if you have a problem with tight-fitting crowns or open margins, it may not be your technique at all. It may be the disinfecting. And what we found out from the laboratory is that people that disinfect, and I found this out, and I've changed my whole sequence of events now just based upon that, is that what would happen is that you would disinfect it, it would then go to the laboratory, and then they would disinfect it. So I would disinfect with brand X, and then they would disinfect with something else. So that could have some effects on the impression material. So just be careful, talk with your laboratory, find out what they're disinfecting with, because it can definitely have an effect. There are some legal requirements that we have to do. We have to disinfect. There's some what's going to be most cost effective. So I went back and forth between the manufacturers of the disinfecting solutions and the impression making people, and I asked them, what do you disinfect with? And they say, go see the disinfecting people. And I go to disinfecting people, they tell me, see the impression people. So I got really frustrated with it, so I basically came up with what you should disinfect it with. So if you're using alginates, it's basically a bleach solution, hydrocolloids. You can use a bleach spray, wrap it up, soak it in there for about 10 minutes, and then rinse it off and then pour it up. If you're using polysulfates, it's basically a 1 to 10 bleach solution. Condensation silicones, you can use glutaraldehyde or bleach. The ones that we're really concerned about would be the addition silicones, the polyvinyl siloxanes. You can rinse these in a bleach, glutaraldehyde for 10 to 15 minutes. But if you leach it out, if you do it too long, what happens is the surfactants, or basically the soaps in the impression material, leach out. That's why do you think that most manufacturers put different tastes, peppermint and mint and things into the impression materials, is to camouflage the soaps. So the surfactants will leach out. It will be dimensionally unstable, so you don't want to do it for too long. Polyethers, on the other hand, use 2% glutaraldehyde, no more than 10 minutes. If you're doing it longer than that, again, they're kind of hydrophilic. They will absorb moisture, and they could have dimensional stability issues and causing tight-fitting crowns or ill-fitting crowns. So be careful with that. Some other disinfectants that are out there, this happens to be from VibraClean. This is from Heraeus. What I like about this one in particular is that it actually will kill, it'll kill HIV virus that's out there, which I care about it, but it's not as stable, and it will die it's a pretty fragile thing. It's the TB that lasts a little bit longer. That's the one I really like to make sure it gets killed. So this is just one to look at. You can take a look at some other ones that you like. There's a lot out there. going to take just a quick second here, kind of get your brain going, because I'm going to go into tray selection. And I know we're going quickly, but I still want to get through a lot of this material and show you some of the bad impressions that are out there. If you're looking at this slide right now, this is a slide of 100 different rock bands that are there, and I'll just kind of show you a few just so you can see this. We got the Smashing Pumpkins, we have the Eagles, we have U2, this is 50 Cent, Guns N' Roses, we got Whitesnake, we got the B-52s. You get the gist of it. Well, anyway, let's get into impression trays. Well, what do we need from an impression tray, and why is this important? Well, it's to carry the impression material. It's to get the adaptation to the tooth structure so that we can transfer it to the laboratory and be able to get a solid model from it. And that's why we need a tray. And what kind of tray should we use, and how should we select it? Well, it should feel comfortable to the patient. It should extend to a certain degree. It should have about 2 or 3 millimeters around, so you can have a bulk of material, so it can be rigid and not flimsy and not distort. It should go beyond the third molars. It should go beyond the tuberosity areas or retromolar pads, depending on where you are. And you should look at the occlusal and the size of the edges and all the way around the tooth, so that it's even and there's no ability for it to be distorted. And we have a ton of trays out there. I mean, there's plastic trays with holes, without holes, metal trays. And as I said, most clinicians will take a plastic tray or a metal tray, and they'll spend most of their time trying to change it, shape it, reshape it to make it fit, whereas a custom tray with using like a triad unit, making a custom tray, or they even have other type of light cured materials. You don't have to buy a triad machine. You can buy other materials that are over the counter and just make it off a model and very, very quickly. So some of the things you want to kind of troubleshoot when you're using a tray is that you use an adhesive. And people say, well, why do I want to use an adhesive? I never use that. I thought that was just kind of a gimmick. Well, it's really not, because the adhesive, you got to think of it as it's like a bonding agent for the impression material. It counteracts the polymerization shrinkage that's going on in the impression material. It's holding the impression material to the tray. Well, you'll say, well, the mesh is holding it, the holes are holding it. Well, not really. You really need that. You need that adhesive there, and you need to put enough of it, but not in globs, because if you put it globbed on, it will definitely affect it. How quickly or how soon should you paint all your trays with adhesive, like 10 days ahead of time? The answer to that would be no. You should really paint it on about 5-10 minutes prior to taking the final impression, and not any sooner than that, because you will affect the final outcome. So polyether is like polyether adhesive, polyvinyl is like polyvinyl adhesive. Try not to mix them up. So let's show you some bad impressions that actually some of your colleagues have had out there. Here's one, no tray adhesive, or not enough of it, and then didn't come over it, not using enough of the impression material, causing a bad impression. Here's one that they had the tray with the holes in it, but no adhesive at all. So it causes a problem, pulls it away when it gets poured up, so that can be an issue, causing distortions. So some of the biggest problems is shrinkage on this, pulling away from the tray, inadequate or improper tray adhesive is used, causing distortions, causing ill-fitting castings, and open proximal contacts. So just definitely try to use the adhesive if you can. It will definitely make a difference for you. Timing's another issue. A lot of people do this. One clinical tip: if you can take this away, and you're using a two-step system like this, a light body and heavy body, take this away. When you're using light body material, always push the material in front of you. Never pull the material, because that dragging and pulling the material will cause a drag or a void in your final impression more times than not. And also, while you're doing this around the impression, go around twice and making sure that you have enough material. When you're putting the heavy body into the tray, put a little bit of the light body in the area where you're going to impregnate onto the final restoration, on the prepared tooth. Put a little bit of the light body onto the heavy body, and then seat it. The lights will attract to each other, and you'll get less bubbles or voids. Again, push the impression material ahead of you. Go around it circumferentially two times around, making sure that you seal everything. Some of the other things that we have to get these syringing around it, we have a lot of people who complain that syringes are just a waste of material and you use too much. Well, 3M came up with a different type of syringe, which is kind of cool, especially in second molar areas, where you would use on polyvinyl siloxane, it had a 1-to-1 ratio, and polyether has a 2-to-1 ratio, and you can just kind of see how this impression tip is different in using less material than a traditional tip, and even the gun itself. So you can see how much smaller that is to get into certain tight areas. And I really do like that. I feel like I'm not wasting as much. Again, properly seat the impression into the patient's mouth. Make sure you firmly put it on both sides pressure, not just one side lopping it off, because that'll cause a problem. And when you take it out, make sure you snap it out. You kind of rock it a little bit and then snap it out to break that seal. As you're moving along, you can see some of the problems that we've had with impressions. We've got contamination. We have bubbles and voids. You may not see this in a final impression, but a laboratory is going to see this, but they're not going to talk to you about it because they're afraid to talk to you about it. They don't want to lose you as a client. What is this caused by? This is usually caused by powder in the gloves, or some other contaminant, or it could be some of the hemostatic agents that are causing it. So just be careful you're doing it. Is this an accurate impression? Well, it's either a very accurate impression of a bad preparation, or it's just a bad impression. My best guess here is that it's a bad impression. It's timing issues. It's just bad detail here. It's got cracking, and laboratories see this all the time. It's amazing what they see. So, troubleshooting this basic problem, just make sure you look at the gloves, make sure you're not touching the impression all over once you're done with it. And when you're taking a cartridge, make sure you extrude a little bit, waste a little bit, because inside here sometimes there's a little bit of plastic and the base and catalyst won't come out right. So just be careful with that. Look at the manufacturing dates, because some of the manufacturers will do it and they won't rotate their stock, and you might have outdated material, or you're not rotating your material enough, so be careful with that. And also where it's coming from. Environmental conditions can set materials quicker or slower depending if you're in Arizona or wherever the case may be. As we're moving along here, we want to get an accurate impression. This is not an accurate impression. They got cheap here. They didn't want to put enough adhesive on it, and so forth and so on. Very bad impression. Now, is this a good impression or a bad impression? Well, overall, it's not a bad impression. We basically have all the margins here, maybe a little bit of a blip here, but overall, not a bad impression. However, it wasn't fully seated here. So what's going to happen? The laboratory is going to do their job. It's going to fit, and the problem is going to come back when you have it in the chair, and you're going to spend about a half hour trying to trim this because the occlusion is going to be off. So function and aesthetics is not going to be working here. So again, we know where the problem is. It's the lab, or is it? In this case, it's us. So just be careful with that. Triple trays. Is it going to fit? People's tongues become 3 times the size when you first start off. They push, they move. We don't use enough material. It's not rigid enough. This is going to fit. Once you relieve this, it's going to be tight fitting or an open margin. So be careful with that. So troubleshooting this problem, get the right tray. Make sure the patient's biting down properly. Use custom trays. Those are going to happen. That's going to be the best case for you, or at least get a full arch tray that's going to fit well. Quadrant tray for implants? I don't think so. This isn't going to work too well in the cases. Accurate impression? Nope, not going to happen here either. I don't even know how laboratories finish something like this. If you see something like this in this nature, what's going to happen is you're going to see it very, very wet. You got tray adhesive. Do you need it? It's got the holes. Yeah, use the tray adhesive. It's going to help. Guessing margins. We're going to use the full arch here. You got pretty accurate, pretty accurate, pretty accurate, pretty accurate, pretty accurate. Well, they kind of know where I was going. So get a good impression material. What happens if I want to use a matrix and I cut out the material? No, you're going to have delamination. This is going to be another issue. So delamination, use a custom tray, use a separate matrix for your provisional materials. Don't try to cut it out. I'm going to stop here in just 1 minute. I just want to see this. What causes this? This is basically when you're syringing around the impression material, and this happens whether you're right-handed or left-handed, you're going around, and you'll pop up. And your hand will just kind of pop up. I'm hoping I have a couple extra minutes because we had technical difficulties. But we basically popped up here, and so keep it in intimate contact all the time and always push the material in front of you. So what's the main reason from our survey of what we found out for poor impressions? Basically, it was inaccurate, unclear margins. And what was the solution for this? Use better trays. That was one of the biggest issues from laboratories. Just use a better tray, and we can get better impressions. So some impressioning tips is really try to tissue condition it. Use chlorhexidine for 2 weeks pre-op and post-op. That would really help. Don't place the margins too subgingival. Use good tissue packing, 2-cord technique. Leave the cord in for about 8-10 minutes, and that's going to give you a good final impression. So let's talk about what the real cost of a final impression is if you have to keep retaking it. Well, if you look at the material costs, the time costs, retake costs, and adjustment costs, if we break it down, we got it basically about $7 for material. You can go back and forth on this, but let's say $7 for material. You had cord placement about 5 minutes, setup time 5 minutes, mixing time about a minute, syringe and seat impression about a minute. Thank you. And we have setting time for 5 minutes and evaluation 1 minute. Total chair time equals about 18 minutes. If we take the 18 minutes and we look, this is from a survey from the ADA, basic average production in an office is about $2,500 a day of production. You got an 8-hour workday. Hopefully you're making more of that in production, but let's just say it's $2,500. It breaks down to about $300 per hour, about $5 per minute when you take an impression. So if you take 18 minutes of total cost time to take an impression, and you times it by $5 of cost per minute of your chairside time, it comes out to about $93 time cost per impression, plus you add on the $7 for the material cost. It costs you about $100 per impression. Now, you don't see that because those numbers are in time. All you see is at the end of the month what the impression costs you and the material costs and what the laboratory costs you. So how many impressions does the average dental practice take in a year? They take about 30 crowns a year, about per month, and which comes out about 360 crowns per year. And this kind of breaks down to 12 full or partial dentures, maybe 12 inlays and onlays, and you get about 384 impressions per year. So now if we do the math on this and we really break it down, it costs about $100 for the impression, 384 impressions per year. You're talking about $38,400 that's actually costing you for each impression. So imagine if you're taking 2 or 3 impressions, it's costing you a lot of money. What you really see every month is about $2,300, $2,300 at the end of the year for impression material. So that's such a small amount of the pie versus the time consumption of having to retake something. So, where does this lead us? Well, this leads us to digital impressions. There's about 50 million impressions that are taken per year, and we use this about 140 million worldwide. And from our 2005 survey, 59% responded that they had inadequate impressions. So this is an issue that needs to be resolved. Digital impressions give us instantaneous satisfaction. We get to see what the final outcome is, and if we have to correct it, if it's not right, then we can just redo it over again. We don't have to wait and pour it up and see. It's instantaneous. And there are many different things that can do this. We can eliminate having to take the bad taste for the patient, bad taste in their mouth. We don't have to have shipping costs of impression material or a final impression to the laboratory. We can just basically email a digital image and give it in a file format, and then they can make a model and fabricate it from there. And then, so we have this Lava chairside oral scanner. We have the CEREC units and the new one that just came out. We have the D4D, E4D. And some of them are attached with milling units, some are not, some have powder, some don't. And then we have the Kadent, which is a line now, the iTero, this is powder free. And that gives us a final impression. And so these materials are very, very good. Instant information. They can be a little technique sensitive. It's going to take a little bit of training. But overall, these are very, very good, and this is probably where things are going to be going. So the bottom line is, spend a little bit of time on your trays, spend a little bit of time on your tissue management, taking a look at that, and trying to eliminate having to take that second impression, because that's going to cost you basically chairside time and money and aggravation for you and for the patient and to the laboratory. So communication is really the key. I am going to stop there. I thank you for your time. I know I went through a lot of information in a very short period of time. I'm going to look through some of the questions and we'll try to get to them and see what's going on. I do apologize for some of the, I don't know, we had some technical difficulties for some reason, and I do apologize that. So if there are any questions out there, I'd be happy to answer them. Yeah, I'm just kind of looking through these. Let's see what we got here now. Well, the question is, would I recommend a metal or a plastic triple tray for final impressions? Well, with a triple tray, you want to have as much rigidity as possible. The only problem with the metal triple trays is that if you don't seat it correctly, especially with patients that have third molars, what ends up happening is you end up biting on them, and you'll get a good impression still, but what will happen is you'll do a lot of occlusal adjustments. So either tray works as long as you put the right enough material into them and making sure that fits. So I have no personal preference if I'm metal or plastic. I probably lean more toward the plastic. Question comes in, what do you mean by pushing the light body material in the prep? Well, when you're taking the final impression, we're using a two-step system. I know in Europe and some of the Asian countries, they like to use a one monophase system. In the United States, we like to use a two-step system where we have a light body runnier material, has more adaptability around the preparation, and then using a heavy body material inside the impression tray. So what I'm talking about is taking that light body material, actually placing it onto the tooth and then pushing the material in front of you, because as I said, if you don't push the material and you pull the material, you'll find that you get more bubbles and voids and drags than if you do by pushing the material around it and just looping it around. So that's what I mean by that. I hope that answers that. The question is, do I usually leave the first cord in when taking a final impression, or do you remove both? That's actually a very good question, because it really depends on the situation. If I have very thin, friable tissue, I'm very reluctant to put cord in, only because I'm very, very careful with that, because I don't want any recession, especially in the anterior. But normally, I would remove both the cords. Whether it's a single cord system that I'm using or not. Predominantly now, I'm using a lot more of the lasers, like a CO2, or I'm using a diode laser. But an anterior, if I'm doing veneers, what I usually do is I prepare it down to the gingival tissue. I will then put like a 0 or a 0, into the patient's sulcus, excuse me, and then I would leave it there. And then just prepare right down to the cord, leave it there, and then take my final impression, because then I'm going to get a nice emergence profile for the veneer. But other than that, I would just take it out. What type of diode lasers do you use? Well, I would, there's a lot out there. There's so many. They've all come down in price. I know Ivoclar has a good one, and there's so many other ones that are out there, and I'm not really endorsing anyone in particular. They're all going to pretty much do what you want it to do, especially for this. And diode lasers are great. They're very cheap. They've come down to about $5,000, $6,000, but they're definitely under $10,000 now, which is phenomenal. And it's definitely helped my practice quite a bit. Question is, do diode lasers cause more recession? Yes, they can if used improperly. So if you're going to use the laser, what I would suggest very strongly is that you train yourself in that and take some courses on how to use it properly, because they can definitely cause some recession, just like an e-surgery can too. So if it's used improperly, you can cause a problem. Let me just see here. Better than 2 consecutive layers of light body. Okay. Does the technique where you put one layer of light body, then blow air to push it more into the sulcus, and then use another layer of light body really work better than 2 consecutive layers of light body? Well, I'm not trying to blow any air into the sulcus at all. That was the older impression materials. We would have to blow air into the sulcus to help get flowability. Now what we're doing is we're not blowing any air on it. We're keeping it slightly moist. The surface is slightly moist, not soaking wet. It's got to have some moisture to it. These materials like water. They're hydrophilic in nature. But what I'm doing is I'm actually pushing the material and then going around twice to help eliminate that little blip that we saw at the end on that last impression I was showing you what caused that. It was basically when you pull up. When you pull up, the material drag comes with you. So you want to make sure you keep pushing it around and keep it into the sulcus. Let me see. let's see if we can get around here. All right. In my opinion, how effective is the retraction capsule material? I think extremely effective because it's really just Expasil. It's really the same. It's really the same product. What they've done is they've just kind of made a better mousetrap. The percentages of the aluminum chloride are different, but overall, it's really the same material. And that tip, that retraction tip that goes inside, that's really the key of it. What Expasil had the problem with is that you had that peri press, and they had to use the metal tip because it would break, and that's why you couldn't have a small lumen on it. And so that's how 3M has come around that. So that retraction capsule works extremely well. So if you haven't tried it, I would definitely I would recommend that. Let's see. What do you think of a putty wash system? I don't have any problems with putty wash systems. If it's working for you, fine. I use a light body, heavy body material. I just like the flowability of it. Again, if you're changing materials, just make sure that, you know, it takes a few trial and error to use it. So don't switch materials. Oh, and the other thing of it is don't use a light body of one material with a heavy body of another manufacturer, because it could be timing issues, it could be setting issues too. There are new materials that are out there that are even faster. That'll set in maybe 2 minutes, less than, if you wanted to. Again, be careful what material you're using, because if you're doing a full arch restoration and you're using a fast set material that's super fast, it can definitely be a problem. Let's see what we got here. Okay. Any recommendations on how to keep a patient's tongue still and place a full arch tray with material on lower second molars for final impressions? This is definitely a problem. It's amazing. As long as I've been practicing, it is amazing how huge that tongue gets. It's just, the minute you put something in some people's mouths, the tongue just kind of gets in the way, and you're ending up spending half your time fighting it, and it's very difficult. I don't have any real secret to it. The only thing I can tell you is if you're taking a triple arch impression, the one thing I found out is that if I practice with the patient without any impression material, and I would do that with the full arch too, just practice with the patient, have them just placing the tray inside their mouth in and out, or closing on a triple tray, and try that technique. But other than that, there's no real secret to it. I'm sorry. I wish I had a magic wand for that one. Let's see. The question is, do I recommend a single cord or a double cord technique? For the most part, I'm going to use a single cord, but I'm going to use a modification of that with a single cord with either in combination with a diode laser or one of the hemostatic agents. The retraction cord along with it, or just that alone. I can't say for every case. It really comes down to the clinical situation of what I'm presented with. So, but for the most part, I'm going to use one cord with some modification with it. Again, a hemostatic agent of some sort, or a diode laser or something of that nature. How do I feel about stock quadrant trays for single unit impressions? I can tell you, as I said, I'm a practicing dentist, and I'm practical. Do I use a quadrant tray for a single impression? Say it's tooth number 19, a lower molar or an upper molar or whatever. Yeah, I'm going to use a quadrant tray. If you ask me as a purist, what would be the best? A full arch would be the best. But I'm cheap, just like the rest of you guys out there, and I'm going to use a quadrant tray. It's for the most part, it can work well. I got some limitations to it. But again, if I'm working with the same lab, they kind of know what to expect. But give them a good impression, and it'll work well. But for multiple units, 3 units and beyond, boom. I'm just using either a full arch or a custom tray predominantly. I don't even mess around with it. It's not worth it. Let's see. Yes. One of the comments again, Ultradent makes Vigastat, which is clear, and I'm well aware of that aluminum chloride. Except it doesn't work as well as the traditional one, the original one. It works, but I still like the one with the ferric sulfate in it. And again, the advantage of it is that it doesn't stain. So let's see what else we got. I think we've hit pretty much all the questions. Some of these we got some repeats here. Oh, we got some up here. Sorry. One of the questions here was recent studies have shown that double cords to take an impression causes gum retraction. What is your experience in the long term? I would agree with that statement for the most part. Unfortunately, not all the way. It depends on how it's placed clinically. If you're really packing that cord and you're meeting resistance, yes, you can cause gum retraction and recession. So that's why I like to call it more placing of the cord, and that's why I'm using one cord along with a modification with a diode laser or with some hemostatic agents. Okay, this is a question. This is kind of interesting. When I'm doing multiple preparations, should you start anterior and move posterior, or vice versa? I usually like to use move from the posterior to the anterior, only because the posterior is usually more difficult for me to make sure that I actually get a good impression or get the impression material into the right spot. It's easier as I move anteriorly and I can see the tray. It's really a timing issue. You've got to be moving quickly. Your assistant has to be in sync with you and making sure that that's going to work. Let's see. Let's see what I got here. How can you... how soon can you pour up a polyvinyl siloxane impression material? Pretty much after you disinfect it, I would let it sit for about an hour, and you can pour it up after like 10-15 minutes, but I would let it sit for about an hour, especially after you've disinfected it. Again, I didn't get to point this out, but based upon that survey that I was showing you, I used to disinfect all my impression materials. Now what I do is I basically rinse off any visible contaminants, and I put it in a sealed OSHA bag and then send it to my laboratory, because I know that my laboratory is going to disinfect it again, and I don't want to have any type of distortions whatsoever. So they know that that's happening, and I'd rather not disinfect it. So, but again, they're trying to protect their employees, and I understand that. Again, I just don't want to have any problems with my crowns or having to redo them. Question is, how far subgingivally do you keep the margins for crown preps? Normally, you have to keep them, you got to look at the biologic width of what it is. So I'm working up my treatment plan with the patients. I'm doing perio probing, seeing what the pocket sulcus is, making sure there's no perio. So usually I would go anywhere between a half to a millimeter below the subgingival. On average. But again, it also depends on what you have clinically. I mean, sometimes you're replacing older preparations. Let's see, we just have time for a couple more here. It says, do we need to rinse the prep after using any type of hemostatic agent like aluminum chloride and ferric sulfate? Yes, especially ferric sulfate. Rinse it off numerous times because it will affect the final impression. It can definitely impede it and cause distortions. Let's see. What else we got here? Let's see. Let's see. If it's ever good. I think we're almost there. Any tips? Any tips on using quadrant trays? Yeah, I'm going to tell you this one tip, and it's actually kind of funny. When I'm using a quadrant tray, I practice with the patient, and I'll have them bite down back and forth, and I'll go, okay, Mrs. Jones, you ready? And then all of a sudden, when I get the final impression, they always try to go strange on you. They start biting kind of strange and going off to the side, and they both go left and right. So what I do is I have them put it in, I put the tray in, and I go, bite! And as I do that, and they get scared, they bite down, and then it usually works. So listen, I thank you for your attention tonight. I hope you've enjoyed it, and we will talk to you soon. Have a great night. Thank you.